Hello, everyone. Welcome to the PermanenteDocs Chat. Thank you for joining or listening from wherever you may be. I'm your host, Alex McDonald. I practice family and sports medicine here in Fontana, California, as part of the Southern California Permanente Medical Group. Although the public health emergency is over, COVID is still with us. And today we're going to be talking about COVID and long COVID with Dr. Tarquin Collis, who is the Chief of Infectious Disease at the Hawaii Permanente Medical Group. So Tarquin, thank you so much for joining us today.
Hey, glad to be here. Thanks for having me.
Great. So if you're listening live or watching live and you have questions, please feel to drop them in the Q&A and we'll get to as many of those as we can. But we're going to keep this high yield and we're just going to jump right in. So Dr. Collis, tell us who you are and what you do.
Yeah, so I'm the Chief of ID, as you mentioned, in the Kaiser Hawaii region, and I also oversee the medical specialties, so help with lots of non-surgical specialties, all of their recruiting and sort of program management.
Great. Well, there was a recent Lancet report that showed that the state of Hawaii had one of the lowest death rates of COVID during the pandemic. And I want to ask you about that. Why do you think Hawaii had this lower death rate than the rest of the country? And what do you think you could attribute that to, or hypothesize what that low death rate may be attributed to in the state of Hawaii?
Yeah, I think it's probably a couple things. Not all of them were addressed in that report. I think, we do have the advantage of being surrounded by a couple thousand miles of water. So I think early in the pandemic, we were lucky in the sense that we could really sort of isolate the same way that places like Taiwan and New Zealand did. And that helped, I think, a lot. Really, probably what it did is allow us to wait until a lot of folks were vaccinated before we were having large outbreaks of kind of community-based transmission. And I think that helped really decrease the death rate a lot. I think another thing that really, we're proud of here and lucky about is that Hawaii's had nearly universal health insurance since about the mid-1970s, one of only a couple of states to do that. And so, access to care is a big issue in terms of COVID mortality. And I think we're blessed in that respect because there are so few uninsured folks. One thing that the paper pointed out, which I thought was really interesting, was one of their big predictors of statewide mortality. And again, Hawaii had about a quarter of the mortality of states like Arizona from COVID, was actually degrees of interpersonal trust. That came out as like a major predictor in the study. And, what's that about exactly? We don't really know. But I think what it probably means is, the inverse really is a lack of distrust. And so I think people are more likely to believe that they should get vaccinated or to mask to prevent infecting others, and sort of a bit of a community-based focus and a little less political divisiveness, I think really went a long way here in terms of helping people adhere to public health mandates and trust doctors about what evidence-based practice is and isn't. And that came out as a really interesting finding in the study that I thought was cool and kind of reflected, I think, what our own experience here was.
Yeah, that's really interesting. I know a lot of the information, at least initially coming out around vaccination and masking, some of the kind of the testing talking points that they looked at were people were less likely to be motivated out of a sense of sort of responsibility for the community or everyone doing their part, seemed to be less of a motivating factors for the vast majority of Americans versus maybe it was the inverse there in Hawaii, which I think is really, really very interesting, actually.
Yeah, it's kind of funky. I mean, we're a long ways from, we're sort of, I always tell people we are part of the United States, but we're almost like a different country in a way. And I think there's also a pretty heavy Asian influence in terms of the acceptance of masking. It's very commonly practiced in South Korea and Japan long before this pandemic. And there's a little bit of a bleed into that here. So I think between a good sense of community and a bit of aloha spirit and a lack of political divisiveness and a non-controversial approach to masking, we were very lucky.
Interesting. Yeah, very interesting. Well, obviously, as I said, COVID is still with us. It's not nearly as dangerous as it was during the height of the pandemic. But we also have this thing called long COVID. I had never heard of the term long COVID before a couple of years ago. I'm sure many of our both our physicians and non-healthcare listeners haven't heard that term before. So what is long COVID? I mean, how is it diagnosed? And really, are there any specific treatments? Help us understand this sort of phenomenon, which seems to be another kind of novel piece of this coronavirus.
Yeah, it's been a fascinating thing to sort of try and understand this. I think we're a ways from completely understanding it. There's a couple of definitions floating around there for long COVID. CDC's definition is pretty inclusive. It's basically if you have symptoms 4 weeks after, 4 weeks or longer after your acute infection. The WHO has a different definition, which is more stringent. You have to have been like 3 months out from the infection and have had at least 2 months of symptoms. But if you think of it broadly as just having persistent symptoms well after your recovery, or even new symptoms, by the way, developing well after your recovery from the acute infection, then you're in the right sort of ballpark. I think the reality is what we call long COVID is a pretty umbrella term, and there's a lot of different symptom complexes and sort of phenotypes of symptoms that fall under that umbrella. For some people, it's brain fog. For others, it's something closer to chronic fatigue syndrome. For others, it's issues with shortness of breath or palpitations or postural hypotension. And what we're really trying to figure out is, are all of those phenotypes united under sort of one pathophysiology, or are there different forms of immune activation, persistent viruses, microclotting, hypercortisolism? There's a bunch of different pathophysiologies that may underlie a lot of the symptoms. And I think we may come to a much better understanding down the road of what's what. There really isn't a blood test, for example. It's really a syndromic definition of what long COVID is and isn't. And that's just something that we're sort of stuck with. Sorry, my light just went out, by the way, so I may look a little, but that's how it goes. And in terms of treatment, because I think we don't understand, what long COVID is yet at the microscopic level, our treatments are really not there yet. We have a much better understanding of maybe how to prevent long COVID than we do how to treat it just yet.
Yeah. I mean, I think of this somewhat coming from my sports medicine background. Obviously, I see and treat a lot of concussions, which again, it's a clinical diagnosis. There's no blood test for concussion. There's lots of different ways that people can present with a concussion. And then there's those kind of concussion sequelae as well, too. And the way that I was trained for sports medicine is you really sort of treat the symptoms of the post-concussion syndrome. And it may have there may be some ideas that sort of a concussion will sort of unmask sort of an underlying condition. So somebody who had a little bit of anxiety gets a concussion and they have more anxiety. Somebody who had a little bit of or maybe mild migraines gets a concussion, they get more severe migraines. Can we think of COVID in that sense, or we just don't have enough information yet?
Well, I think that's a great point. I think a lot of long COVID clinics, and we can talk about that. That's something that we're doing here. Do focus right now on symptom management, because that's one of the few things we can offer. And we do have, I think, evolving ways to manage different symptoms depending on what they are. And that can be anything from, helping invoke cardiology or neurology's help with folks who suffer from postural hypotension, dealing with tachycardias or shortness of breath, in different ways with medications, managing brain fog, working with physical therapists in terms of fatigue. There's a lot of it is around dealing with the sequelae rather than the underlying cause just yet. Right. I do hope that down the road, we'll have a much better understanding and be able to offer treatments to resolve rather than just manage the symptoms. But I think we're a distance from that just yet.
Yeah, that makes sense. And this is a question that came through the chat, which I have a lot. It was on my list, actually. So whoever dropped this question, thank you. How are clinicians being trained to see these sort of potentially random symptoms as all part of long COVID rather than just sort of other random symptomatology? And we have patients coming in with fatigue all the time. How do we say, oh, this is long COVID, chronic fatigue syndrome versus just good old fashioned chronic fatigue syndrome, I guess, for lack of a better term?
Yeah, I think that as with most things in medicine, it's just a growing understanding and an ongoing education of the workforce. We're lucky here to have started a long COVID clinic last year. A couple of other Kaiser regions are doing so or have done so. KP Northwest and KP Colorado, I know, are involved in that same effort. And it really does help to have a specialty referral center either within your institution or outside of it. Because you're right, there is a lot of overlap between a ton of these symptoms and other forms of disease that can cause similar symptoms. In our long COVID clinic, which is actually not run out of my department, it's run by a single doc here, Abby Pandula, who's wonderful. And if you're ever looking for another guest from Hawaii, she's fantastic. She's an internist and a really thoughtful doc. a part of her initial evaluation is really to make sure that there isn't another cause for the symptoms, whether that's hypothyroidism or heart failure, et cetera. A second focus, as we talked about, is symptom management. And then, one thing that's really interesting, and I've talked to her about this at some length, is that what she feels, one of the things she really provides to patients who do have long COVID is just an acknowledgement that they have something real and they're dealing with something, and making them feel heard, and, having some hope that someone will help walk them through this, because it is a newly sort of evolving paradigm as a disease and as a symptom complex. And it's nice to feel like someone understands that.
I think that's such a key point, is sort of validating anything in medicine, but especially something as sort of poorly understood as this, is just sort of validating the patient, that they're heard, and that they're being taken seriously, not just sort of being blown off as well. I think that's such an important piece, and across medicine, but especially for something like this, which is relatively new and poorly understood as well too. I do want to chat about the long COVID clinic, actually. But I have one quick question before that, and that's more about, are there other viral syndromes which produce these kind of prolonged symptoms afterwards? I mean, we have long COVID, but do we have, anything else, any other viral type infections, or is this something unique to COVID?
Well, I think that's actually a great question. The truth is that long COVID really joins a list of a lot of other post-infectious syndromes that honestly we haven't paid all that much attention to or understood all that well. Chronic fatigue syndrome, or myalgic encephalomyelitis is the other term for that, has many causes, but among the best established of them are Epstein-Barr virus and fever and Ross River virus. So there are certain infections that clearly are precipitants in some patients to chronic fatigue. They're really well-established, long post-infectious syndromes after chikungunya infection, after Ebola virus. One thing that gives me a little pause is that, there are some post-viral infectious syndromes that can take a long time to develop. For example, after the 1918 flu pandemic, it was clearly recognized, although it took a few years, that there was a form of Parkinsonism that clearly followed as a sequelae from some of those patients' infections. And then, we still deal with something called post-polio syndrome. So this isn't paralytic polio so much as something that occurs 30 or 40 years, sometimes 3 or 4 decades after polio, where people develop muscle atrophy and breathing problems and fatigue and joint pain. And so one of the things that we're sort of watching for in the long COVID world is whether there will be new syndromes that actually join into the fray later on, that take a long time to develop after COVID. The hope is that there's so much money and research pouring into long COVID right now, which is great, is that maybe we can refract some of that onto some of these other problems that we've been dealing with for a long time in infectious disease, and which may offer some hope for some folks with other sort of related pathophysiologically symptoms from other viruses, which would be great.
Yeah. No, that makes perfect sense too. I think there's just such an intense focus on COVID, and long COVID is so much more discussed, I guess, in the lay press as well too, that more people are aware of it and they're kind of bringing it forwards as well, versus some of those maybe slightly more defined post-viral syndromes, but less attention, so to speak. So thanks for clarifying that point. I appreciate it. So tell us more about this long COVID clinic in Honolulu. What is the role of that clinic? What is the strategy? And what are kind of some of the ways they're addressing this condition?
Yeah, it's certainly been a very busy clinic for Abby, and people refer from either specialties or primary care directly into the clinic. It often starts off as an e-consult. She reviews the charts, sort of gets a better sense of what's happening, and more often than not brings the patient in to be seen. They have a pretty long intake evaluation, involving a careful physical exam and a long series of questions to really sort out where the issues lie in terms of symptomatology. And then, as I mentioned, she really tries to make sure that there's no other simply fixable explanation that may be masquerading as long COVID, and then engages the patient in a fairly long course of sustained support and symptom approaches to making people feel better. We're trying to hook her up with some research efforts. There's several long COVID clinics, UCSF and Mount Sinai and Yale, that are doing some really interesting research in this world. And I hope that we do manage to establish those ties and expand, so that we can actually help to answer some of these questions about what we should be doing.
Yeah. Yeah. I mean, is that enough, having just one person do this? Is there a big demand for this clinic? And if, how can we sort of maybe replicate these efforts other places as well too?
Yeah, I think there probably will need to be either another Abby or more of Abby's time dedicated to this, because it's become very busy. I think it's been a real boon for her colleagues in primary care. It's very hard to address these things in a 20-minute visit, right? And she makes more time for the patients than that. Some of it edges into, almost like behavioral health approaches to helping people feel validated and supported. And so I do think it'll likely expand over time. What we're trying to figure out, of course, in the bigger picture is long COVID becoming less frequent as our sort of collective immunity increases. There are some data to suggest that long COVID is less frequent now if you're infecting a population that has some degree of baseline immunity because they've been vaccinated and boosted and infected previously, as most people have. Maybe we will see less long COVID over time. But if that's not the case, right, if in fact it's going to be a steadily growing problem just with the number of people that are infected over time, then I think we will definitely have to expand. So I think it's both a field and a clinic in active evolution, and it'll be kind of exciting to see where things go.
Yeah. Yeah. Do we have any idea of what percentage of people develop long COVID, or is there's not enough data or tracking to kind of wrap our hands around that information or that number?
Yeah, I think part of the issue is that the definition shifts that percentage around a lot, right? If you're just kind of saying how many people feel kind of junky a month out, that's a lot of people. If it's more stringent and are you 3 months out and feeling really debilitated, that's a much smaller percentage. So it shifts with the definition. And then of course, the earlier sort of experiences with COVID, where it was a much more devastating infection for a lot of people who were in the ICU and hospitalized, is very different than now. And so again, our understanding of how frequent it is becomes a lot harder to manage when most people are being diagnosed with home antigen tests rather than formally, et cetera.
Right.
And a lot of people probably aren't even being diagnosed. It's probably south of 5% of people that are severely debilitated nowadays after their COVID experience, but it ain't zero, that's for sure. Right. And we're still seeing new patients pop up all the time.
Yeah, I have a couple patients just that I care for as their primary care doctor who just have debilitating symptoms a year, 2 years out even, and it's just I don't know what to do for them. I feel so stuck sometimes too. And so there was a question here in the chat, which is sort of similar. I'm going to kind of merge them into one here. So it sounds like we're a ways off from any actual treatment of long COVID, or even understanding kind of the pathophysiology of long COVID. Does it matter if you just treat the symptoms of long COVID versus sort of the underlying kind of what we may think may be the pathophysiology? So that's, I guess, the first part. And the second part, does vaccination or anything help to prevent long COVID? I guess that's ultimately the goal, is to prevent the illness in the first place.
Sure. I think to answer the first question, I think that I don't think there's a harm in treating symptomatically while we wait for more defined approaches. There are some data suggesting that at least in a subset of patients, viral persistence may be the real issue. There's a big study going on now called Stop PASC, which is an NIH-based study, and Stanford's participating in that, looking at treating folks with long COVID with 15 days of Paxlovid, interestingly enough, to see if some subset of patients do harbor some residual virus and to see whether that helps. And then there are some immune-based therapies that I think will be really interesting to see whether, if in fact the issue is really inflammation or autoimmunity, whether we can alter those. But I think we're a distance from figuring out how to best get at the heart of the matter. And until then, I think symptom management is basically all we've got effectively.
Right.
In terms of the second question, what are the things that we think prevent long COVID from starting in the first place? There are a couple of data points there that are pretty interesting. Vaccination, being vaccinated before you're infected, does seem to prevent long COVID. The estimates of how great an effect that is vary between studies. It's somewhere between 15 and 40% in most of the big studies that have looked at this. So it's another reason to be, as well vaccinated as you can be. There are some really interesting data suggesting that treating the acute infection really may help prevent long COVID down the road. So There's a big study that came out looking at the VA experience with Paxlovid, and it suggested about a 26% decrease in long COVID in those that received Paxlovid when they were acutely infected. I think that one of the better reasons to take Paxlovid, honestly.
Interesting.
There was a better study in a way, which hasn't been as well talked about. The Japanese use a drug called ensitrelvir. It's sort of their oral Paxlovid equivalent. And in their registration trial, which is actually a prospective treatment trial rather than this cohort-based large study out of the VA, in their treatment trial, they showed about a 45% decrease in long COVID in patients who were treated during their acute infection. And that may be closer to what we see. So if the virus is in fact causal directly, and you can shorten the exposure to the virus with a good antiviral, that may be a really important approach. And then the last one, there's a really interesting study, very provocative study in the Lancet, part of the COVID Out trial, which is also a prospective trial, that showed that taking metformin for 2 weeks during your acute infection decreased the risk of long COVID by about 42%. That's not really ready for prime time yet, but metformin does have both antiviral and anti-inflammatory processes at play. And so there's some interesting follow-up studies looking at whether metformin may actually have a role when you're acutely infected. So I think we'll gain a better understanding, again, as we understand what the heck this thing really is, about how to prevent it. But I think that those are the early studies we're looking at so far that give us some clues.
Wow, that's really interesting. I hadn't heard that about metformin, and that's something we use all the time in primary care. So that's really interesting. So this is great. We could probably go on and on. I want to ask two more quick questions. One is what's next for COVID? I mean, are we going to see sort of a predictable seasonal pattern like we do with flu? Are we going to need annual vaccinations? We're going to have our Fluvid vaccine where we get flu and COVID every fall. Is it too early to know where we're going yet?
Sure. I think I think the two factors that are probably going to have the most to say about that are really what the virus does, obviously, and then how our vaccines evolve. Mm-hmm. And so if you think about the virus, really since November of 2021, so for maybe the past 18 months, we've been dealing exclusively really with the children and grandchildren and great-great-grandchildren of Omicron. We've stayed within the Omicron family from BA1 all the way through XBB. And in that context, our immune systems are doing pretty well in warding off severe infections and waves of infections. And I think as long as we stay there, that'd be awesome. Then I think we might be an evolution to a seasonal pattern. What we don't know is whether the virus will do another big leap forward. And there's a lot of reasons to believe that it might. There's a lot of bright minds that are trying to estimate how likely that might be, that it takes a big genetic leap. It can infect up to about 30 different animal species. It's a worldwide infection. There's a lot of immunocompromised hosts who can inadvertently serve as sort of incubators for viral evolution. So if it takes another big hop, we could certainly see a movement away from low-grade seasonal infections towards something much more like our first, year's experience, which I certainly hope to happen. Yeah. And then in parallel to that is the race of vaccine development. And, we had our current vaccines, which are excellent, developed through Operation Warp Speed. There's a new government sort of supported initiative called Project NextGen, which has pumped about $5 billion into looking at new vaccines, whether that's mucosal vaccines. A lot of the work from Akiko Iwasaki at Yale is looking at that. We're using a nasal vaccine in India right now. That's an intellectual property out of WashU. And looking at, pan-sarbecovirus vaccines that are variant proof. So I think as the virus evolves and as our vaccines evolve, both of those things will have a lot to say about where the pandemic actually, or the endemic state actually evolves to down the road.
So in short, stay tuned.
Yeah, that's it. Big time.
Got it. Awesome. Well, okay. Last question. This is wonderful. It's such a wonderful information. I wish we had more time. But last question: What makes you most proud to be a Permanente physician?
Whoosh. Well, I guess, staying on the theme of the day, it's been neat to be part of an organization during the COVID pandemic that I think has done things the right way. I have a bunch of friends in the community who work in different hospital systems or in public health, and they were really impressed with how Kaiser in Hawaii and Kaiser nationally approached the pandemic in terms of sticking with evidence-based practice and working in a collegial fashion and really jumping into the community to help with vaccinating underprivileged groups and those at high risk. And so that's been a really neat thing to see. And I think just on a personal level, I saw a lot of people run into the burning house to help others rather than running away from it. Really proud of my colleagues and proud to be a part of that effort.
Well said. Very well said. Well, thank you so much for joining us today and sharing your expertise, Dr. Collis. Thank you. That's all I got.
You're welcome. You take care of yourself.